This is case study number 11. Patient presenting with abdominal pain. Pretty cool one. Let's get to thinking. All right, guys, you guys know the deal. These cases are made up. They're not real. We make them for educational purposes only. All righty. So first thing, here we go. You got a 65-year-old female. Whoopsie. You got a 65-year-old female. She comes in to the ED with a past medical history of atrial fibrillation, hypertension, and just a recent diagnosis of diverticulosis. She presents to the Ninja Nerd Clinic, actually. Let's say the Ninja Nerd Emergency Department, with an acute onset of constant, non-radiating, diffuse abdominal pain without any kind of palliative factor. So nothing has been helping at all to relieve this pain. She's just begging for help to relieve the pain. She also says that she has some associated nausea, vomiting. You ask her when her last bowel movement was, and she says it was around 10 hours ago. Okie dokie. So 69-year-old female, past medical history, AFib, hypertension, recent diagnosis of diverticulosis, comes in with diffuse, non-radiating, acute onset abdominal pain, which nothing is making it better. She has associated nausea, vomiting, and a bowel movement about 10 hours ago. You walk into the room. When you walk into the room, you notice on the vitals, like on the actual camera, or on the vital signs there, you notice that she has a heart rate of 150 beats per minute. You notice a respiratory rate of 32. You notice a BP of 110/70. You notice a temp of 101.4 degrees Fahrenheit and an SpO2 of 94%. Okay? So she is tachycardic, she is tachypnic, she is not hypotensive, but she's on like the, a normal range technically. And then temp-wise, she is febrile. And she has an SpO2 of 94%, so she's not hypoxic. So she's definitely tachypnic and tachycardic and febrile. Cardiovascular-wise, she is tachycardic. She has an irregular rhythm. She has an S1 and S2 that's heard normal. You don't hear any other murmurs, rubs, or gallops. Okay? Pulmonary-wise, she's tachypnic. You can visibly see that. And she has some bibasilar crackles, but no wheezing or rhonchi. Abdominal-wise, she is just grimacing in pain, okay, while she's holding her abdomen. But when you go over to touch it, it's not really hard. It's nice and soft. It's non-tender. She has normal active bowel sounds when you're listening there, and she doesn't even really have any rebound tenderness, okay? So right now we have a patient who is 65, female, history of AFib, hypertension, diverticulosis, diffuse abdominal pain, acute in onset, non-radiating, nausea, vomiting, bowel movement 10 hours ago, tachypnic, tachycardic, febrile, and in grimacing pain with really no obvious signs on her abdominal exam that are, really could point to why she's having this pain. Okay? I hope that makes sense. So with all of that being said, from our history and our physical examination, what's your suspected diagnosis? What's your differential? And you guys got to go through all of your different thoughts here about abdominal pain. It's a pretty broad differential, and you're supposed to use a couple different things. Utilize their history, utilize their physical exam, particularly where is their abdominal pain? Is it in the right upper quadrant? Is it in the left upper quadrant? Is it periumbilical? Is it left lower? Is it right lower? Is it diffuse? Those are all things to be thinking about. But if I were to just kind of give you guys a very generalized, broad differential diagnosis that I'm going to give you guys options here, which one of these do you guys have a high suspicion about? Okay, maybe it's a couple of them. Maybe it's none of them. Maybe it's only one of them that you guys are really, really thinking about. But which one out of these do you guys definitely have a high suspicion about? And maybe if nothing is on this list, put in the comment box what else you guys are thinking about. Okay, so some are saying mesenteric ischemia. Some are saying cholecystitis. Someone's saying maybe complicated diverticulitis. Acute bowel ischemia, GI bleed, small bowel obstruction, acute mesenteric ischemia. So it's a lot of them are coming between bowel obstruction and mesenteric ischemia. Someone asked a really good question. Jazz Medicine, a really good question. Is she anticoagulated? No, she's not taking any anticoagulation. Great question. Super good question. Can we rule out appendicitis because of no rebound tenderness? You can think about it. There's also those other tests that you learn in school that you got to be thinking about, right? So you can perform, you can think about like McBurney's point tenderness, your Rosving signed. So those are other things that you could be thinking about. But no, I don't think it's completely off the table. Okay. Cholecystitis, acute mesenteric ischemia. So I'm getting a good chunk of acute mesenteric ischemia, bowel obstruction. I'm kind of getting a mixture, and that's okay. We can't definitively say like what we think it exactly is, but it seems like the most common one that's coming up here is acute mesenteric ischemia. Small bowel obstruction is coming up, and some diverticulitis and some bowel perf is coming up a lot. And I think that's a pretty good differential. I think you guys are doing a great job. Okay, so these are some of the things that we're thinking about. The good thing to do from here is, let's say that we have this as our differential. Things to be thinking about with some of these in a perfect scenario is pancreatitis. We should think about what are the risk factors. Gallstones. Is there any kind of alcoholic, are they an alcohol abuser of some kind? That could be a trigger. Do they have hyperlipidemia? Is there any steroid use? Is there any particular drugs that they're on that could be a potential trigger? Do they have mumps virus? You guys remember the mnemonic for pancreatitis, I get smashed. That's kind of a helpful way to think about potential etiologies. But the most common ones is going to be, alcohol abuse and gallstones. By far. She doesn't have any alcohol use. She doesn't have, at this point, we don't know if she has gallstones. She could. We don't know that. So there's a potential. But pancreatitis usually presents with kind of like an epigastric, kind of maybe mid-abdominal pain that can kind of start radiating to the back. Okay, and then they could present with some hypotension. They could present with tachycardia. They can present with fever. Small bowel obstruction, again, think about particular things. Small bowel obstruction, it could be due to some type of mass. She is older. It could be like cancer related. She doesn't have any history of any kind of recent abdominal surgeries. That's a very, very common cause, is like adhesions secondary to multiple kind of abdominal surgeries of some kind. Again, there's also if she had like a hernia, if there's certain things that could potentially make me think bowel obstruction, that's possible. But bowel obstruction, you usually think about some type of abdominal pain. You think about vomiting, you think about abdominal distension, and potentially, again, some tenderness upon palpating the abdomen with some history of some kind of abdominal surgery, usually in a perfect clinical vignette case. Appendicitis, right lower quadrant abdominal pain is the classic sign. They have, pain whenever you're palpating in their left lower quadrant and you're releasing. Sometimes it can cause some pain that kind of refers or radiates to that right lower quadrant. They can have McBurney's point tenderness. Usually when you're kind of lifting, they have what's called that iliac, like the iliopsoas kind of test. When you're lifting up their leg, you're flexing at the hip, it can kind of compress and squeeze near that appendix, and that can cause some pain. But again, hers isn't really right lower quadrant. Usually with appendicitis, you have way more like localized pain. It can kind of radiate to like the periumbilical region. And if it does perforate, you can get some signs of peritonitis. But usually there's some more pain upon palpating the abdomen. AAA is definitely a possibility. She's older. All right, so she's 65. She's female. She has hypertension. We don't have any history of her smoking. She says that she denies smoking. We don't also know what her lipid panel looks like as well. She could have hyperlipidemia, which is another trigger. But she's older. She's female. She has a history of hypertension. There is no definitive smoking history. But again, it's possible because that can potentially be a significant thing to think about, especially if that ruptures and then she develops significant hypotension or hemorrhagic shock. That's a big thing to think about. Pyelonephritis, she doesn't have any flank pain. It doesn't radiate. But again, it's something to think about. She does have fever. She does have some diffuse abdominal pain that's maybe difficult to identify. It's a potential for a pyelonephritis. Peptic ulcer disease, again, this is another thing to think about. Usually that's kind of like an epigastric pain, usually kind of a burning one, radiates to the back. Also want to think about this in patients who, there is NSAID use. That's a potential thing, but it's usually like Helicobacter pylori. And the pain depends upon where it is. If it's a duodenal ulcer or if it's a gastric ulcer, the pain kind of differentiating those depends upon when they're eating, if they're developing pain when they're eating or if they're developing pain after they're eating. But usually it's somewhere around that. Acute mesenteric ischemia, she has atrial fibrillation, and someone asked a great question, which is she's not on any anticoagulation. So that's a good thing to be thinking about, because if she is on anticoagulation, there's some form of basically trying to prevent her from forming clots on that valve that could pop off and potentially embolize enteric vessels is a potential thing to think about here. Diverticulitis, she's older. She has a history of diverticulosis. She didn't complain of any obvious GI bleed, like lower, like bright red blood per rectum. But it's a possibility. She has a fever. Usually that's a little bit more left lower quadrant pain, but it's something to think about with her recent diagnosis of diverticulitis. So that's a possibility. Cholecystitis, right upper quadrant abdominal pain. Again, usually with that one, you can have fever. Usually there's a positive Murphy sign. Again, things to think about here. It's a possibility. Bowel perf, it's unlikely since she doesn't really have any super rigidity of the abdomen. She's not super hemodynamically unstable at this moment. And usually there is some like rebound tenderness and just rigidity of the abdomen. Nephrolithiasis, it's a possibility. Again, kind of lower on the differential. But I think a lot of you guys made a pretty good, like for the most part, differential out of these, which is most of you guys have said acute mesenteric ischemia, diverticulitis. Some of you guys said some small bowel obstruction. I don't think that that's a bad idea, but I think, yeah, pretty good stuff so far. Okay, let's move on. So we got our kind of some of the things that we're thinking about. The next thing, that now that we kind of have a good idea of their history, their physical exam, we have a differential running through our head at this point in time. What labs would be the things that you would say, okay, hey, can we start off with these, because these might help me to potentially rule out some of these things. So you got to think about it. These are some of the things that we have on our differential here. Is there any labs that I could order here to say, okay, this potentially could rule out this condition, or it's still I don't have enough evidence to rule this out yet? It just kind of is going to help me to determine, to kind of go through my differential and say, what kind of labs could I order that would help me out at least somewhere in this to say, it's unlikely that it's this, or it's still likely that it's this. Okay. What do you guys think? Okay, we got some tons of labs. We got CBC, BMP, ABG. We got some coags. We got hepatic, so LFTs. Fecal occult blood test. I think someone meant to put U. I think Toyo meant U and A. So UA, urinalysis, lipase amylase, blood cultures. Okay. CRP, lactate. Yeah, I think all of these are great, man. You guys are awesome. One of you guys picked one that I didn't think of, which I think is not a bad idea. And it's a good idea. I actually probably should have put that down. So good call on the blood cultures. I did not put that down, but she does have a fever. It's not a bad idea to start some blood cultures, but yeah, we can start with the CBC first, but I don't think it's a bad idea to have a consideration of someone coming in with just this very diffuse abdominal pain, nothing really specific on their actual physical exam that really points out what's going on with the abdomen. Having a fever, not really like hypotensive or anything, but it's not a bad idea since they're tachycardic, they're febrile, they're tachypnic. I don't think it's a bad idea. So CRP, ESR, those are okay. I'm not a big fan of CRP and ESR. They can sometimes be helpful, but the question that I want you guys to ask yourself is, what would they tell me? How would that help me in my diagnosis? It's going to tell me that there's some generalized inflammation. I don't think it's going to point me towards a diagnosis. It's not a bad thing to order. I just don't think it's going to be super helpful to get that. But I think most of these are pretty good. So let's go ahead and see what we ordered, right? Here we go. We ordered a bunch of those tests. I'm just going to say that the other one that somebody asked about, the blood cultures, they were negative. Okay, that was a good one though. That was a good thought. But here's what we got as our lab results. So on the lab results, our CBC came back. We got a white count, 20K. Woo. So they got a leukocytosis. We got their CMP back. Their anion gap is 14. Their bicarb is 16, which is low. UA within normal limits. ABG pH is 7.25, so they're acidotic. Their PO2 is 84, so they're not hypoxemic. They're within the 80 to 100 range. 46 is their CO2. It's just like 1 point higher than normal, so it's not super significant. And their bicarb is 15. Okay? So we have so far a leukocytosis, an anion gap metabolic acidosis based upon their bicarb and their ABG from their CMP here. Their lactate is 5.8. So I got a lactic acidosis. So you always want to think about that, right? If someone has an anion gap metabolic acidosis, if you guys watched our video on metabolic acidosis, think about the three particular things: ketoacidosis, uremic acidosis, lactic acidosis, or some type of toxin or drug-mediated lactic acidosis. Toxin or drug-mediated acidosis. So we have our reason here, which is the fact that she has a lactate of 5.8. So we know that she has a lactic acidosis, a leukocytosis. Her lipase and amylase it's within the normal limits. Her type and screen, just in case, you can always order a type and screen in case you suspect that this person needs blood. A positive. Her troponins, I was kind of surprised. So sometimes, here's a big thing to think about. I missed it one time. Had a patient who came in with some epigastric abdominal pain. Anytime someone has abdominal pain, you should always be thinking about the potential of an MI, especially inferior myocardial infarctions. I think someone might have said it in there, but don't forget about those, okay? Just because someone's presenting with abdominal pain doesn't rule out that there's something going on with the heart. Sometimes the referred pain from an inferior MI could potentially be something that is actually kind of causing that radiating abdominal pain. So don't forget it. So you want to get like an EKG and correlate it with their troponins. Their troponins were negative, thank goodness, right? So the troponins were less than 0.02, so normal. And you got some serial ones too. Her fecal occult blood test was negative as well. So she doesn't have any like obvious blood on her exam, okay? Let's see what you guys are saying here. I just want to check it out here. Okay, is it too early to do endoscopy? Yeah, I would say so. When to perform an x-ray of the abdomen, we'll get there. Very non-specific, this soon on. Amylase lipase. Sorry, I'm just looking at you guys. So why is patient acidotic? That's a good question. We'll get to it in a second. Well, hey, actually, let's think about it now. What's causes for lactic acidosis? Why? What would make you guys think of lactic acidosis? Like, what are some potential causes? There's two types, type A, type B. Type A tells us that there's some type of hypoperfusion to the tissue, not enough oxygen is being delivered to the tissue. If not enough oxygen is being delivered to the tissue, your process of glucose getting converted into pyruvate and then into acetyl-CoA, right? That step from pyruvate to acetyl-CoA is going to be hindered. You aren't able to convert pyruvate into acetyl-CoA. Instead, ththose NADHs can't be used in the electron transport chain. They dump it off on pyruvate, shunting it into making lactate. So there's something that's causing her to not get enough perfusion to the tissue. That's one potential cause. The second one is type B. There's some drug-mediated inhibition of the mitochondrial or electron transport chain in some kind that's potentially inhibiting her from being able to make ATP, or inhibiting some aspect there that's altering her aerobic cellular respiration, Krebs cycle, electron transport chain. There's no real drugs that she's on right now that's going to cause the type B, so I'm leaning more towards type A. Type A lactic acidosis, you got to think about this. Type A lactic acidosis would be due to what? Could be due to something's wrong with the lungs. The lungs aren't being able to oxygenate, okay, to bring oxygen in. And if they aren't able to bring oxygen in, get into the blood, there's low oxygen, it's a hypoxemia from the lungs. Okay, that's one potential thing. She's satting 94%. She is a little tachypnic, but that could be because she's acidotic and trying to breathe off her CO2. That's one potential reason. Okay. It also could be that she has a low blood volume. So if she has a low blood volume, there's less blood that's actually being delivered to the tissue. That's less oxygen being delivered to the tissue. That's also causing the lactate bump. Her blood pressure was on the low-ish side, okay? If we slap on the ultrasound and we look to see what her IVC tells us, let's say that it says that it's indeterminate. She's somewhat fluid responsive, but not like super collapsed. Okay, so I'm not leaning towards that. Other things to think about is, does she have like sepsis? Is there an infection, a systemic infection that's causing her to be septic? And therefore she's having a lot of leaky capillaries and a lot of her effective arterial blood volume is dropping. Does she have severe anemia where she doesn't have enough red blood cells to be able to deliver oxygen to the tissues? Or is there a clot that's blocking blood flow to an organ, and therefore that organ is not getting oxygen and it's starting to spit out lactate as a byproduct? Okay? So that is the things to think about of why she could have potentially a lactic acidosis. Okay, so I think at this point we can rule out that it's a hypoxemia from the lungs. She doesn't look like her CBC was, only thing that was pertinent was her white cell count, so she doesn't have a severe anemia. On her blood pressure, she's not super tanking. She could be septic. She has a white count. We don't know if she has an identified infection. I did tell you her blood cultures were negative. Her UA is normal. We got a chest x-ray. That didn't really show anything. So I'm kind of leaning toward not being septic. And again, we established that her IVC wasn't like super collapsible. She wasn't super volume down. We gave her some fluid boluses and she kind of improved a little bit. But I'm kind of leaning towards the other option here is there a clot somewhere? And that clot is obstructing blood flow to the organ and the organ isn't getting perfused and therefore it's spitting out lactate. Could be. Her lipase and amylase is within normal limits. What can that kind of, it's not a guarantee, but what can that kind of rule out at this point? Can you guys tell me what we can at least say I have a low suspicion of this now? Just reading you guys' comments while you guys are answering and stuff. What could I say again out of amylase and lipase? Kind of for the yeah, good job. It's not a clear rule out, but I have a lower suspicion of pancreatitis for the most part. So at the most part, I kind of at least ruled out that. Her troponins were negative. I haven't looked at her EKG yet, so I can't say that she doesn't have an MI yet. I don't have enough other tests. I know that she doesn't have an obvious GI bleed right now. Her fecal occult blood test is negative. So it's tough to say. I still don't have really enough. I could just say I have a kind of a lower suspicion of her having any kind of pancreatitis. A cholecystitis, generally there's some kind of elevation in bili. There's a potential to have an elevation in their LFTs. Those were all normal. I'm not saying that, again, it's not possible, but I'm not like super, confident and suspicious of cholecystitis. Peptic ulcer disease is unlikely to cause a massive white count like this. It's unlikely. Nephrolithiasis is unlikely to cause a massive white count like this. Pyelonephritis could still do this. Appendicitis, you can get an elevated white count, and if she did perf, there's a potential that she could have some underlying sepsis. Again, we're not super confident about what's going on here yet. Okay, I think we can kind of say that from the lab results. All right. So, what images would you guys want? So we haven't completely ruled everything out. I'd say for the most part, we have a low suspicion of pancreatitis. I'd say I have a lower suspicion of peptic ulcer disease. I'd say I have a lower suspicion of cholecystitis. I have a lower suspicion of nephrolithiasis. Based on her exam, I also am not like super enthusiastic about a bowel perf, but I don't want to miss anything. I still think she could have diverticulitis. I still think that she could have acute mesenteric ischemia. There's still a possibility of pyelo. AAA, I'm not really leaning towards that either. AAAs aren't generally just going to cause a massive leukocytosis and fever. I'm not leaning towards that either. So, I kind of have a low suspicion of some of them and a relatively higher suspicion of others. Okay? So you guys tell me what images you want and we'll think about those. Okay. X-ray. I'm all about it. I love just simple, quick, tests that you can just order. It's a really quick, like if we had to, if she's relatively unstable, you can get a portable abdominal x-ray, or you can take her to x-ray if she's relatively stable at this point in time. So I think an x-ray is a great thing. Ultrasound, you can't go wrong with an ultrasound. You can do it bedside, or you can get a formal ultrasound. I'm a big believer of being able to perform point of care ultrasound at bedside. Can really speed up some processes and just help in aiding in your diagnosis in a quicker rate. Lolly 95, she was not a smoker. Like when we talked about her history, there was no underlying kind of social history of tobacco abuse or tobacco use. Good question though. So yeah, get an abdominal x-ray, ultrasound. What else do people like? A CT of the abdomen. Okay, with contrast. Sounds good. Yeah, and you could do a CT. I think someone was saying CT with contrast. You could do it with oral contrast, or you can do it, with IV contrast. You can do both. So you could do a CT, oral contrast, IV contrast, and just hit it in the different phases. Maybe you want it in the arterial phase. Maybe you want it in the venous phase for the IV contrast. And then if you do the, with the oral contrast, it's going to light up parts of your GI tract. So, Alana, why would you avoid any contrast imaging? So, Jazz and Medicine, you have to hurry up. CT IV contrast. I would agree with that. I think that's a good idea. But yeah, if you want to do a quick abdominal x-ray, there's no hurt in that. If you have ease of access, usually the x-ray techs are within near close by proximity of the ER. It's a quick, easy thing that usually they're on standby. You can have them come in, shoot a quick abdominal x-ray, and then take a look, and then send them over to CT. X-ray, I think you may potentially miss something if you don't get the CT. That's not to say it's not possible for you to pick something up. But if you get an x-ray, it might help to rule out something like a pneumoperitoneum, any obvious obstructive bowel signs. If you get an ultrasound, it could help to potentially rule out any kind of cholecystitis, ductal dilation, any perinephritic fat stranding, peripancreatic fat stranding. Maybe even you could throw on some Doppler and potentially to see if there's any decreased flow in any areas. That's potential, but it's not a complete thing to rule out some of these conditions. Sayara, so she did get a CMP and her renal function was normal. So she has no issues with her creatinine. She has no issues with her GFR. And again, here's another big thing. Maybe we'll talk about this in the future, but contrast-induced nephropathy should not be a reason why you do not give someone contrast in an emergent situation that requires an immediate diagnosis. That should not hinder you from performing an exam. You can always fluid resuscitate them, give them tons of fluid as a contrast prep, and then get the study, but it should never hinder you from performing a study that is necessary to diagnose and potentially treat something that could be serious. I'm sorry, I don't mean to be crazy. I have a very big pet peeve about contrast studies. I think that it's one of those things that, again, it should never hinder you from performing a study. If there's a way that you can get a diagnostic test, a definitive diagnosis, it should not be something that hinders you from doing that test. You get more acute kidney injury from drugs that we prescribe commonly, like vancomycin, that can cause more significant acute kidney injury than contrast will. Sorry, I'm going to get off my pedestal. I apologize. A little bit of a pet peeve for me for that one. Okay. So I think we got, for the most part, we're going to start off with an x-ray. We'll then go ahead and get an ultrasound. We'll get a CT. Some people want a CT with contrast. And then we can get a CT angiogram, I think somebody else said. I think those are good tests. Alrighty, so we get an abdominal x-ray. No bowel obstruction. There's no pneumoperitoneum. Okay? There should be no bowel obstruction, no pneumoperitoneum. CT with oral contrast. It showed no obvious bowel obstruction. There was no gastric thickening. There was no peripancreatic or perinephritic fat stranding. No obvious appendicitis. The abdominal aorta was 3.5 centimeters, so it's not dilated. Ultrasound of the abdomen with Doppler showed that there was no cholecystitis, no pancreatitis, there was no hydro, there was no appendicitis present. Her abdominal aorta was 3.5 centimeters, and she has decreased flow in her SMA. CTA of the abdomen showed an occlusion of the superior mesenteric artery. Okay? So if you wouldn't have gotten the CT, you could have potentially missed it. Now, that's not to say if you got the ultrasound of the abdomen with Doppler, you couldn't have said, there's a decreased flow in the SMA. Why? But you should probably confirm that with an actual test, which is a CTA or an angiogram. Okay? And I think, so great. So she has ischemia to the bowel. So someone's like, so it's the occlusion that causes the lactic acidosis. Exactly. So she has ischemia. One of the big things that you guys have to remember that's super important when you're thinking about this for your exams is if a patient comes in, they're a woman, they're greater than 60 years of age, they also have history of atrial fibrillation, and they have diffuse abdominal pain that's out of proportion to what their abdominal physical exam it kind of indicates, high suspicion right away for acute mesenteric ischemia. Okay? Again, I'll repeat that. Greater than 60 years of age, female, history of atrial fibrillation, and someone asked an amazing question in there. Is she on anticoagulation? No. Diffuse abdominal pain, acute in onset, and associated nausea, vomiting, and a physical exam that is, she's got this pain that is just disproportionate to what her abdominal physical exam finding is, have a high suspicion for acute mesenteric ischemia. Okay? It's good to be thinking about all these other things and we can rule those out. Have the differential. Think about what labs and imaging will help me to rule those things out and rule in something else. Okay? So, I think that for the most part gives us our diagnosis. Another thing that helps us with our diagnosis is an EKG. We were asking about that, and I think someone also said, did she have an MI? Well, let's look here. If we take a look at her EKG, what do? We determine our rate first. It always should be rate. We can see that there's about 2 boxes between here. It's irregular. You could count all of the R waves and then multiply it by 6. You could take, for the most part, finding an area where it's at least, between the R waves, it's at least 2 boxes. So she's around 150 beats per minute. We also had that on the monitor that she was around 150. So we know that she's around 150 beats per minute-ish. We look to see the rhythm. Is it regular, irregular? There's variation in her R to R interval. It's irregular, right? Is it sinus? Do we have P waves in lead 2? Well, there's no definitive P waves that I see in lead 2. I see my QRS, I see my T wave. You could say, I wonder if this is a P wave. It's tough to say, right? We look at our AVR, and the AVR should be inverted. I don't see any obvious inverted P waves here. I kind of actually see little fibrillatory waves. But there's no obvious P wave that is upright in lead 2 and inverted in AVR. So therefore, I can't say that it's sinus rhythm. Because again, I don't have I have what maybe looks like an upright P wave, but it should be inverted in AVR, correct? And the way we can do this, let's say that we find an area that we think could be a P wave. Let's say that we think okay, I think this is a P wave, and I follow this all the way up. There should be an inverted P wave in AVR that lines up with that. There isn't. So therefore, I don't think that this is an obvious sign of sinus rhythm. What would we do next? Okay, well, what kind of rhythm is it? Well, we can have a differential in our heads. Tachycardia, irregular rhythm, no obvious sinus rhythm, okay? We should think about AFib, atrial flutter, which is in a variable conduction block, or multifocal atrial tachycardia. I don't see any, again, differences in P waves. And how do we determine the difference between flutter and AFib? The best lead to look at, your money lead for atrial activity, is V1. Look at that. Look at that crap there. There's all of these fibrillatory waves here in V1. That's your money lead. Okay, so she's an obvious AFib. The next thing is to say, does she have any ST segment elevation, ST segment depression? Because that was something that we were trying to look for. Well, I don't really appreciate any ST segment elevation or depression in really any of my inferior leads. I don't appreciate really any. In my lateral leads, I don't appreciate any ST segment elevation or depression. In my septal leads, I don't appreciate any. Again, there's always a discordance between your septal leads. But if you follow Scarbosa's criteria, this would not fit Scarbosa C criteria. And again, I don't appreciate any ST segment elevation or depression in any of my precordial leads. So again, with that being said, I don't have a very high suspicion of an NSTEMI or a STEMI. Okay? So what's likely to happen that happened with this lady is that she probably was in atrial fibrillation. There was inadequate atrial kicks. She had decreased flow from the atria down into the ventricles, leading to a embolus or a clot that formed in the atria wall within its left atrial appendage on the left atrial mitral valve. Then what happened is she popped that clot off. It then floated into the left ventricle, into the aorta, down the aorta, off the superior mesenteric artery, got lodged there, and decreased the blood flow downstream to the organs that the superior mesenteric artery supplies, which is the bowels. And she's probably starting to just begin to infarct those actual organs, those small bowel parts of her organs, okay? So anything that's supplied by the superior mesenteric artery, in this case her small bowel, is probably beginning to infarct. It hasn't infarcted enough where she's actually started to bleed. Usually that's a little bit more of a later sign where they develop the current jelly bloody stools, but she's getting there. And so this is something that we need to take care of pretty quickly, okay? So good thing that we've, at this point in time, we have a female greater than 60. She has AFib, not on anticoagulation, obvious AFib. She has diffuse abdominal pain, her pain is out of proportion to her exam. We have definitive diagnosis on our CTA, okay? The most gold standard diagnosis is an angiogram though. So next question is, what's our diagnosis? We know. It's acute mesenteric ischemia secondary to atrial fibrillation, not on anticoagulation. Okay? You guys did great. So, what's the treatment? What are we going to give her? What are we going to give her, guys? What should I treat her with? Okay, let's say the first thing to think about, which subtype of CK would increase? That's a good question, Nate Gardner. You could also see a CK. You could also definitely see a CPK elevation as well. Good question. I think that's a great question. So yeah, expect to also, I forgot to put that in here, but that's a great question. CPK will also potentially be elevated from potentially some of the, infarcting of the bowel wall. There's also smooth muscle within that area as well. And so there's definitely a potential that you could infarct some of the bowel wall, releasing some of the CK from those smooth muscle cells. So definitely great. Okay, so some people are saying, I think thrombolytic treatment is a priority. I would agree with you. Yep. Heparin. Yep. How long has she had AFib without anticoagulation? I want to talk to her cardiologist. Yeah, that's a good thing. yeah, she probably should have been on anticoagulation. Definitely. So oversight potentially on the PCP or the cardiologist. How do you guys determine need for anticoagulation? What's the two MD Calc scoring systems that you should utilize to determine if this patient needs long-term anticoagulation, and then use that risk versus benefit? There's two scoring systems that you guys should utilize to think about that. Margaret, you're funny. Yeah, Denton, that's true, man. It's a good thing it didn't go to her brain. Yeah, Ilana, great. Chad Vask, yep. Chad Vask is a good thing to determine if she has, the need for anticoagulation. Then, yep, Christina has bled score is a good thing to determine, the risk from being on anticoagulation. And does the risk, is the benefit of being on anticoagulation going to, outweigh the potential risk of having bleeds associated with that? So that's a good question. Good question. All right. So sorry, I got all distracted with that. So the treatment for her is we got to give her some fluids. Okay. So she's not hypotensive, but she's probably starting to infarct her bowel. Okay. Well, she obviously is starting to infarct her bowel because, again, if she has that lactic acidosis, she's probably starting to infarct the bowel because she hasn't had enough oxygen being delivered to the small bowel. So she's probably starting to infarct that. And then she's definitely at risk if she infarcts that small bowel. That part of the bowel will stop working effectively and she can start developing a obstruction proximal to that. So we got to give her fluids, got to give her tons of fluids. We want to put an NG tube in kind of prophylactically in case she's not able to, if she does start infarcting that bowel and we have to decompress the bowel proximal to where the infarct is, we should have an NG tube that's able to do that for us. Antiemetics should also be there because she does have some nausea. She's in insane amounts of pain. So we should give her analgesia and then we should give her antibiotics. Why should we give her antibiotics? I want you guys to think about that. If she started to infarct her bowel wall, what is the problem with that and why should we start her on antibiotics? Not just because the white count's elevated. Definitely that's one reason. And because she's febrile. But what is the fear that if she infarcted her bowel, what is potentially the issue with that? Oh, subashry. I love lactated ringers. To be honest, lactated ringers is there's tons of articles that suggest that LR is superior to normal saline in various categories. The only time where normal saline may be a little bit more preferred is in kind of a neuroscience ICU for patients who have high intracranial pressure. It's not a bad idea to kind of go with the NS, the normal saline. But LR, I pretty much use that for anybody without any other kind of intracranial pressure concern. It's just superior. Yeah, so great. You guys are all saying it is that if she infarcts that bowel, now the bacteria have no true barrier, no true protective barrier that's hindering them from going straight from the GI tract lumen into the actual mesenteric blood. Easily can have bacteremia that can progress to septicemia. Boom. Okay? So I would definitely agree with that. She needs to be on antibiotics. Okay? Margaret, I don't love LR because it's not compatible with anything. Okay. I love LR. I know there's always these questions of is it good with calcium and stuff like that. A lot of the literature says that, there's no problems with calcium. It's not really a concern. Also, like ceftriaxone, just get 2 IVs if you can and run it through different IVs if possible. And then there's even this concern of hyperkalemia. Actually, LR is less likely to cause hyperkalemia, and normal saline is more likely to cause hyperkalemia. Normal saline loves to cause acidosis. Lactate's just a more balanced crystalloid. But anyway, off another pedestal. So we got IV fluids running through her. I prefer LR. Margaret doesn't like that, but that's okay. We got an NG tube to potentially decompress the bowel if the infarct progresses and she doesn't have any motility there. We get antiemetics to stop the nausea. We get analgesics for severe pain. We're going to put them on some broad spectrum antibiotics because there is definitely a risk of her developing some type of septicemia related to that bowel infarct. We're going to start her on anticoagulants, right? Because start her on heparin, that's going to help the progression of the clot. And then we can do plus or minus TPA. I'd probably go ahead and say give her the TPA. So we probably put her on heparin and then give her a hit of TPA to start trying to break up that clot. Another thing to start thinking about here is that there is another drug that sometimes is used. I haven't seen it used too often, but the literature does say that you can consider it. Is if you want to try your best to perfuse parts of the bowel that is still salvageable, you can try to dilate the part of the bowel and some of the blood vessels, actually dilate some of the blood vessels that are serving parts of the bowel that is salvageable, and you can use this drug called papavirin, and it might help in that scenario. Vasopressors, if she did become hypotensive, you probably would oh man, I got to put her on Levophed, I got to put her on phenylephrine, I got to put her on something to help epinephrine, whatever. Actually, you should really try to minimize the inopressors. Those are the ones that you probably want to try to be very, very careful of, because if you squeeze down and clamp on those peripheral vessels, you could potentially reduce blood flow to the bowel even more. That's something to just think about potentially. If I had someone who's becoming hypotensive, I would consider giving them something called an inodilator, like dobutamine, which gives you inotropic contraction as well as dilates the peripheral vessels. Milrinone, same thing. Okay. Margaret's joking, yeah. Yeah, Jazz. So that's a good thing to think about. So TPA, again, it depends upon the scenario. An embolectomy is probably going to be the best scenario for her. But if she's not really like a great surgical candidate at this point in time, you can try heparin. You can do plus or minus TPA. But again, an embolectomy would be a nice thing to do if you can go in there with a catheter. Generally, when you're going to do that anyway, you should have them on heparin. That's why I have plus or minus TPA. Definitely give heparin because you're going to need that generally no matter what to prevent the to prevent the continual development of the clot. Plus or minus TPA is based upon if they're going to get an embolectomy or not. If you go to do an embolectomy, you can do that with a catheter, potentially like a catheter like aspiration, or maybe surgically going in and actually cutting out the emboli. But if that's not a possibility, TPA would kind of be the next go-to in this scenario. Okay. So, you guys, let's say that she got her fluid, she got her NG tube, antiemetics, pain medication, all that good stuff, antibiotics. Eventually, her blood cultures and all that stuff came back, and she didn't have any kind of like obvious positive blood cultures again. Her blood pressure started improving with the fluids. She got her heparin. She didn't need an embolectomy. Let's say the significant kind of like septic bowel perforation, something of that nature. So, great stuff. All right, let me see. Questions here. Okay. Okay, that was a good question I asked before. Okay, why no adenosine? Okay. Why would you want adenosine, I guess, is a question. So adenosine is great for doing what? For blocking the AV node. In atrial fibrillation, you can give adenosine, but it's not going to be a super beneficial thing in patients with AFib. It would be beneficial in someone with an SVT, like a supraventricular tachycardia of some kind. But adenosine, not so great. You can try it. If it doesn't really help, there is other options. Things like beta blockers and calcium channel blockers. I would just be careful. Okay, the only thing here is, and again, this might be a little bit more of like my bias. If a person is hypotensive, on the verge of hypotension, I'm probably not going to reach for a beta blocker or a calcium channel blocker because those can drop your blood pressure. They shouldn't, but they can. I like to give magnesium. Magnesium is a great drug. It really helps to have kind of a rate and rhythm control. So sometimes I'll give a person 2 to 4 grams of magnesium in an infusion. And if they're really hemodynamically unstable and I really want to convert them out of AFib, I may try something like amiodarone. I like amiodarone because it's a little bit more hemodynamically stable. So that's something to think about if you're trying to convert them out of AFib or try to control their AFib. I generally give a mag infusion and I'll try something like amiodarone. If they're hemodynamically more robust, then I'll try to rate control them with a beta blocker, calcium channel blocker, DIG. Okay. Yeah, Denton. Again, you can definitely cardiovert them as well if you wanted to. Definitely a possibility. You just have to, and again, you can chemically cardiovert or you can electrically cardiovert them. Again, in an ED setting, people are more likely to get kind of like an electrical cardioversion. In an ICU setting, I'm a little bit more likely to chemically cardiovert somebody. But you're going to be anticoagulating them anyway, so there's nothing wrong with being able to convert them. Probably in a ICU setting, I would probably go ahead and try to do something like amiodarone and again a mag infusion and see how they respond with that. If I really needed to and they became acutely hemodynamically unstable, I would electrically cardiovert them. But again, I'm more kind of the guy that reaches towards amiodarone and magnesium, a chemical cardioversion. And if they're hemodynamically robust, I rate control them with beta blockers, calcium channel blockers, and something like DIG. If they're acutely hemodynamically unstable and I just need to do something quickly, I will probably electrically cardiovert them. Okay. Another thing to think about is how long has she had this AFib? I didn't really give you an answer. If she's a chronic AFibber, it's going to be a lot harder to get her out of that AFib. If it's an acute AFib, which is not likely, it's not likely that it's an acute AFib, it may be easier to be able to convert her. With a chronic AFib, it's a little bit tougher. So Daniela asked, in order to cardiovert, we need first a TEE to rule out intracardiac clots. It depends. There's some literature. There was like a study out in like the UK that was talking about this, and it's still kind of a tough thing, to be honest with you. In the textbook definition, yes, you should always, if someone's been in AFib for particularly like greater than 48 hours or something of that nature, you should definitely consider like checking to make sure that they don't have an obvious clot. It's likely that she did or does still. That's why she developed kind of a mesenteric ischemia, an acute mesenteric ischemia. But yeah, she's going to get heparinized, so she's going to be getting anticoagulation anyway. So I don't know if it's necessarily that important to be able to go ahead and get a TEE, since you're going to be trying to anticoagulate her anyway. Again, I don't think it's necessary right now. Based upon her condition, you're going to be giving her anticoagulants. And again, just stressing this, I probably wouldn't be working too hard right now on trying to cardiovert this patient and get them back into normal sinus rhythm. It's likely that this is a chronic AFib, and I'm just going to go ahead and try my best to make them hemodynamically stable. And I'll start something with MAG. If they're hemodynamically stable, I'll try something like beta blocker, calcium channel blocker to rate control them. If they are really like hemodynamically unstable and I'm still like they're starting to really tack up away towards the 160s, 170s, and it's starting to affect their blood pressure, I'll reach for something like amiodarone or potentially electrically cardioverse them. I don't see us needing to do that right now. I think that she's tachycardic because of her lactic acidosis, because of her mesenteric ischemia. Okay? Let's see. How do you chemically cardio? Yeah, I think we answered the high white count. We talked about the chemical cardioversion. The Digoxin is hard to initiate and dial in the dose. Yeah, I don't go for DIG. DIG is kind of like a third line agent for. I would do DIG if someone is, they take it at home. It's not hard to kind of go ahead and get that started. You can always load them up with DIG. And then kind of start them on a maintenance dose and then get your DIG levels. But yeah, DIG I'm not super big fan of. It's okay. If it's something that they use at home, I'll go ahead and do that. But you do get a little bit of an inotropic kick and you get a little AV node blockade from it as well. But it's relatively easy to go ahead and start. But it's just probably not something I would start right away. Okay, but let's go ahead and focus back on the real issue, which is our mesenteric ischemia. Okay, so crackles. Why does she have the crackles? Could be a couple reasons. She could potentially have some natural kind of like bibasilar crackles. Sometimes in individuals who get a little bit older, they can naturally have some bibasilar crackles. Could be that she has maybe some underlying heart failure. We didn't really get an echo of her heart, so we don't know what her ejection fraction is. Maybe there's a little bit of backflow into the pulmonary veins. She's not satting, the saturation for O2 isn't significant. We can throw in a chest x-ray. We can throw in potentially, getting an echo a little bit later, seeing if she has any obvious signs of heart failure. And if she needs some diuresis a little bit later, we can do that. But I wouldn't be too worried about the bibasilar crackles. Sorry, just looking here at any other questions that you guys have. How to assess if it wasn't about to perforate or bleed to avoid anticoagulation. Again, it's kind of like, you obviously know the cause here. The person has a clot within one of their vessels and it's starting to infarct their bowel. You have to anticoagulate them. You have to potentially give them thrombolytics or go in there and potentially remove that clot. It's just like, for example, it seems very weird, but in a person who develops what's called a cerebral venous sinus thrombosis, as a clot within one of the veins of their brain. And sometimes they can develop bleeds because of the back pressure behind that clot in the vein. That's a bleed within the brain. Guess what you do? Guess what you treat these patients with cerebral venous sinus thromboses? You treat them with anticoagulation. And it seems like, oh my gosh, they have a bleed. Why would I do that? It's because if I don't take care of that clot, they'll continue to bleed. It's kind of the same concept here. I have to anticoagulate them. I have to either do an embolectomy or give them TPA, because if I don't get rid of that clot, they're going to infarct their entire potential bowel wall and they're going to potentially perforate. Okay. So which ones would I prefer? I'd probably go with Vanc, cover your gram-positive, cefepime or Zosyn to cover your gram-negatives and your Pseudomonas, and then metronidazole to cover any kind of anaerobes. Okay. All right, guys. I hope all of this made sense. I hope you guys all enjoyed it. I know that this was a cool one. I really enjoyed doing this one with you guys. I hope that it helped. I hope that you guys liked it. I hope I was able to answer all of your questions. Again, one of the things I think to think about is that when we do these case studies, try to remember that we're looking at this. I'm trying to do this for two reasons. One is to help us out to look at particular cases and truly try to understand the history, the physical exam, what those things mean, how to potentially pick out diagnoses, how to treat. But also I'm trying to do it in two ways. I'm trying to give this help for your exams, for whenever you have to take your USMLEs or your PANCE or your NCLEX or whatever it may be, but also at the same time try to provide a little bit of clinical context for when you guys have to go out in the wards and treat people. So I hope all of this made sense. I hope that you guys enjoyed it. And Ninja Nerds, I love you. I thank you. And as always, until next time.